One of the things that I am starting to see in my practice more and more as a naturopathic doctor is people coming in their 30s and they're like, I'm in perimenopause. I have fatigue, hot flashes, night sweats, my libido is low, I have anxiety, and my periods are still normal, but I have horrible PMS and I'm going into perimenopause. And these women can be like 34 years old and we think, oh my goodness, like we are starting perimenopause earlier and earlier. And so I want to talk about some of the pieces to consider if you feel like this is you and that you feel you're going into perimenopause earlier than you had anticipated. And I want to explain some of the why behind why these symptoms might be coming up. So, the first thing to understand is that when we look at perimenopause as a stage of life, the average age for this to happen is over the age of 45. And so, if someone in their early 30s is having symptoms as if they're in perimenopause, then we absolutely need to be investigating this. So, kind of like the first piece of the puzzle is that you don't need hormone testing in order to confirm or to say that like you are in perimenopause. But what you do need is you need to understand based on how old you are if something else is causing the symptoms. Now, one of the things that I always say to patients is with perimenopause, the symptoms are vast, right? Like we have vasomotor symptoms, which is like your hot flashes and night sweats. We have our mood symptoms. We have like anxiety and depression. We have brain fog. We have, the period specific symptoms. We also have muscle and joint pain, and we have sleep changes. And, all of these things can be caused by other things, right? So it's important that we're piecing apart and really investigating, okay, is this actually perimenopause? Is this true premature ovarian failure, especially if it's happening younger than we anticipate? Is this something that needs to be supported with hormone therapy? Because truly, if we look at the need for hormone therapy, not every patient is a candidate and it's not going to be the right fit for every single person. But one thing that we can understand is when it comes to hormone replacement therapy, if you went into menopause at the age of 38 and your hormones were truly, you were going truly through ovarian failure prematurely, we would need to give you hormone therapy because we need to protect your cardiovascular health, your bones, right? We know that the longer that you go without estrogen, that can actually be harmful and it's not actually a great thing to have, right? So the first thing is really determining like are you in the stage of life where we should be investigating further, or can we assume because you're in the average age of perimenopause that you're in perimenopause, right? And so a lot of patients will come to me and say, I need to test my hormones. And here's kind of the guideline. If you are over 45 and you're having irregular periods and you're having a plethora of other symptoms, then that would be clinically representing perimenopause and we would treat you as such. Now, would I want to do other blood work? Absolutely. We want to check iron, vitamin D. We want to check vitamin B12. We want to make sure that your cholesterol is good and your inflammatory markers are low. And I always want to look at insulin, but I'm not going to say, let's look at hormones because the reality is when you're in perimenopause, the hormones are doing this, right? They're being extremely erratic. And that is not helpful to test because we could test it one time. One day it looks normal, the next day it doesn't look normal. And so that's not helpful to guide our treatment. And even still, when I put you on hormone replacement therapy, I'm not going to test anything to make sure that you're at the right dose, right? I'm going to just treat you, evaluate your symptoms using our objective tracker and our tools that we use in terms of questionnaires, and then we will treat accordingly. And then if you feel better on that dose, amazing. Because research tells us that when you take estrogen, when you take hormone replacement therapy, your levels might not go up like someone else's levels when you are having symptom relief. So it's not about meeting a certain symptom or meeting a certain serum level to give you symptom relief. It's literally just about how do you feel. But if that same person was having mood swings and hot flashes and night sweats at the age of 38, then we need to make sure that we're looking for other things going on. One of the things that is commonly missed when we're looking at, is someone going through perimenopause? Is this actually perimenopause, or should we be looking at something else? Is the thyroid. So, not many people realize that the thyroid plays a massive role in reproductive health and can be a huge reason why someone is experiencing symptoms that they hadn't before. And so, when we're ruling in and ruling out other diagnoses, we have to look at the thyroid. Similarly, if somebody has PCOS, polycystic ovarian syndrome, they've likely had irregular periods their entire reproductive life. And so we can't go by the change in their periods indicating perimenopause. We have to make sure that we investigate and we rule out other reasons why their symptoms have suddenly changed from here to here. The other thing is if you've had an ablation, if they've actually, removed that inner layer of your uterus, typically women will have this done because they have heavy bleeding. They'll get an ablation. Some of my patients will never get a period again after an ablation. And so, not having a period after an ablation does not mean that you're in menopause yet. Your ovaries could still be producing your hormones completely like they should be. But here's where, that nuanced conversation comes in with respect to testing, right? Here's where we might want to dig a little bit deeper instead of just saying, oh, yeah, no, you are. Similar if somebody's had a hysterectomy, but the ovaries are still there. We want to make sure, like, are those ovaries functioning properly? Should we dive a little bit deeper? If someone is on hormonal birth control, if you're on the IUD, or so the IUD usually actually stops bleeding or reduces it significantly. And it's one of the reasons why a lot of women choose the IUD. But in terms of understanding perimenopause and menopause, if you're on the hormonal IUD, we can't use that as a gauge to understand if you're in perimenopause or menopause based on your bleeding patterns. And so that might be another reason why we would dive deeper and we would investigate further, right? So those are all the kind of some of the nuanced pieces that we need to look at when we're deciding what we look into and how we determine if someone's actually going in to premature ovarian failure, if they're in early perimenopause, or if this is just something else that we're missing. Now we know we have an environment that really is damaging to our hormones. We live in an environment that is extremely highly stimulating and doesn't allow us to rest. And we know that, the women that I work with are busy caring for everybody else but themselves. And so there are a lot of things that increase the symptoms that we experience at a younger age and can feel so much like perimenopause. Again, these conversations are happening daily with my patients. We are seeing this collision between modern life and human physiology, where we have stress, inflammation, metabolic dysfunction, and all of these things are triggering hormonal instability decades earlier than we had originally anticipated. And studies have actually shown an increase in women under 40 reporting perimenopausal like symptoms, specifically in the US and Canada. And one study looked at over 55% of women aged 30 to 35 reported moderate to severe symptoms despite normal hormone fluctuations and regular periods, right? So this is something that we have to look into and we have to take pause. And it doesn't necessarily mean that more women are in perimenopause, but there are so many other things that are disrupting our hormones' ability to function like they would have. So the first one is chronic stress and cortisol dysregulation. We know that we have work demands, parenting, constant digital and nervous system overload. Our nervous system rarely gets a break, right? We have chronic stress flooding the body with cortisol, and this hormone can actually directly interfere with our reproductive health and reproductive function. So we know that high cortisol suppresses your brain's reproductive signaling, so GnRH, which stops ovulation. And if you don't know already, we need ovulation to make progesterone. This is a calming, sleep supporting hormone, it's a mood balancing hormone. And over time, this actually creates a scenario where your estrogen is more erratic and your progesterone's not there to create balance. We also have inflammation. Low grade chronic inflammation is actually a silent driver of hormonal decline. It damages your ovarian tissue, disrupts hormone signaling, and increases your symptom severity. Inflammation can come from really a variety of sources, but I see it from poor diets, specifically with high sugar and processed diets, environmental toxins, chronic infections, sleep deprivation, and also gut issues. And specifically, a study in 2019 found that elevated markers of inflammation were linked to an increased risk of early menopause. So, inflammation ages your ovaries. We also look at insulin resistance and metabolic stress. Insulin resistance is, in my opinion, the most overlooked reason women in their 30s are experiencing hormone chaos. Because essentially, when the cells stop responding properly to insulin, your blood sugar rises and so does inflammation. Your body compensates by making more insulin, which affects ovarian function and hormone regulation. High insulin, which we see in PCOS, also increases testosterone and can interfere with ovulation. It amplifies estrogen fluctuations, creates more mood instability, bloating, and energy crashes. We know that research also validates this. Women with higher fasting insulin tend to experience earlier and more severe hot flashes and night sweats. We also see mitochondrial decline and cellular aging. So, your mitochondria, if we remember in biology class, the powerhouse of the cell, play a major role in hormone production and ovarian health. When they are sluggish, everything slows down: metabolism, repair, and even fertility. We know that mitochondrial dysfunction can develop from chronic stress and poor sleep, nutrient deficiencies like CoQ10, magnesium, B vitamins, iron, and so that is a big thing. And, lastly is looking at environmental toxins and endocrine disruption. We live in an estrogen saturated world. Plastics, pesticides, personal care products often contain endocrine disrupting chemicals or EDCs. And these can mimic or block estrogen receptors in the body. They can also alter the way our body handles hormones. Research shows that high exposure to these chemicals has actually been linked to earlier menopause by up to 2 years, which is crazy. So, I want you to understand that if you are in your 30s and you are feeling like this is perimenopause, it might be. But it also doesn't mean that just because it's not perimenopause, that it's not anything, right? There's still so much we can do. But when we identify and pinpoint the root cause, that is what helps us create a treatment plan that works for you.